So, what are the symptoms in long COVID? What have we seen in our regular OP practice? Yeah. So, this again we have divided two main things. Most common is like constitutional symptoms, which doesn't pertain to any particular system. And second important thing will be neurological complaints. So, these are few which we have enumerated: fatigue, headache, and upper respiratory complaints, that is shortness of breath, sore throat, persistent cough, and loss of smell. Loss of smell is still seen in a lot of people in post-COVID. So dysgeusia, ageusia, and anosmia are still persistent in around 10 to 36% of the patients in long COVID. And multi-system complaints, this is what I was talking about. This includes a huge set, particularly lack of concentration, and other important thing is your, extreme fatigue or weakness at the end of the day is what we come across with a lot of patients. So again, symptoms we have put in a tabular form, and this is the way how we have to consider to approach with long COVID or post-COVID symptoms. Just tabulate all the symptoms what they have, and you have to individually, systematically have to approach and evaluate each patient. Are they having a proper post-COVID scenario, or is it related to any other systemic disease per se? So this is other slide which shows about the percentages of different post-COVID-19 manifestations, symptoms. You see, fatigue is almost around 70%. Anxiety, yes, anxiety could be because of various reasons per se. Patients' neurological damage because of COVID, and the other is psychiatric or patients' regular anxiety behavior because of this post-COVID scenario. The joint pains, headache, chest pain, dementia, depression, blurred vision. So if you see, most of the symptoms are pertaining to neurological, that is psychiatric and non-psychiatric, but still many of the symptoms are pertain to neurological symptoms particularly. Other than neurological symptoms, if you again see, there is a significant involvement of heart. So arrhythmias, palpitations, sweating episodes, dizziness, or this next important system next to neurological system is cardiovascular system, where the patients come up to the clinics. So again, how many? This is again the literature quoting about what are the common symptoms they come. The same thing which we were discussing in the previous slide. So post-COVID categories, as I told, we have a different nomenclature proposed by different bodies. Post-COVID fatigue syndrome, post-COVID cardiorespiratory syndrome. So how do they come up with? So you have to always differentiate the other causes. After differentiating the possible causes, you have to identify, or always keep that in mind. It could be a possible post-COVID, because post-COVID has serious involvement of the immune dysregulation, as well as it has damage at autonomic nervous system also. So that's what we have tabulated. So post-COVID neuropsychiatric syndrome. So these people come up with headaches, anosmia, neurocognitive difficulties, insomnia, depression, and other mental health conditions. So every time before you label them under any post-COVID syndromes, you always make sure that these patients have to be ruled out other systemic illnesses. So one more thing, post-COVID gastrointestinal syndrome. So abdominal discomfort, diarrhea, constipation, vomiting. I think by this time a lot of the doctors, a lot of clinicians also should be aware of COVID also comes with mesenteric vascular ischemia, or they come with a bowel gangrene. So always keep that in mind. Any patients who are coming with severe acute abdomen after post-COVID or during COVID, make sure that you are checking all these particular things. So post-COVID hepatobiliary syndrome, again, same, nausea, jaundice, deranged LFT, with a background history of COVID. We always have to have this clinical suspicion, as well as just rule out all the other possibilities. Uh, Usage of any drugs which is responsible for increase in the jaundice, any blood transfusions recently, any old liver diseases, check their viral markers. So one should have that thing in the brain while ruling out all other possibilities. The next thing is post-COVID musculoskeletal syndrome. Yes, this is more challenging. That You have to check CPK, creatine phosphokinase. You need to check LDH. You need to check uric acid. So make sure that we check all the parameters in this particular people. Many of the times, post-COVID musculoskeletal syndromes come almost a problem similar to connective tissue disorders. They'll come with arthralgias, they come with arthritis, they come with enthesitis, they come with tendinitis. So you have a huge spectrum, varied spectrum of symptoms what the patient can present with. Slowly, you have to enumerate what could be the possible, get the inflammatory markers, get the autoimmune profile if necessary, and we have to differentiate and diagnose these particular conditions. So post-COVID thromboembolic syndrome, I think this by this time everyone should know. COVID is not just prothrombotic state during the COVID acute phase, but even after the acute phase, even in the post-COVID phases also, we get to see this thrombotic events. So depending on the vascular territory of the involvement, breathlessness is seen if it is in pulmonary embolism, chest pain if it is in cardiovascular when coronary artery disease. You see weakness, or you have claudication pain in the limbs, and sometimes cerebrovascular accidents are also seen. So early diagnosis and treatment is life-saving. Follow the standard treatment protocol. Only that we have to have a high index of suspicion in this particular cases. Now coming to post-COVID multi-system inflammatory syndrome. Yes, this is what everyone is scared. This is what everyone is afraid of. I think we'll be sharing a couple of slides on this. I, being a physician who deals with only people beyond 18 years, I think so far MIS is much more addressed or studied in children. But now that we also seen lot of young people who are coming with multi-system inflammatory syndrome. Recently, we have almost 3 cases who fit into this criteria, which has been proposed by CDC. So you look for all other causes, you may not find out, but still you see very high inflammatory markers. Patients come with a very high temperature, nothing less than 101 or 102 degree Fahrenheit, and they come with chills, but you search for any other possible diagnosis you can, it is negative. You don't find any other possible diagnosis. You check for procalcitonin to just rule out bacterial infections here. Procalcitonin is negative, and CRP is very high. Look for WBC counts. WBC counts may not be very high. Sometimes it could be near high normal. So in that cases, you always have to think about post-COVID multi-system inflammatory syndrome. Next, post-COVID genitourinary. So this is also the significant presentation what we come across. So a lot of people, particularly elderly people, they come to the hospital or the clinic presenting with increased frequency of urination or burning micturition or repeated recurrent UTIs and hematuria. So all these people have to be thought about post-COVID genitourinary symptoms, and you can send for urine for culture, ultrasound, PSA in men prostate specific antigen, and if required, these patients have to undergo uh, urethroskopy or ureteroscopy or cystoscopy, whatever is needed, and the further follow-up with their concerned urologist. Coming to post-COVID dermatological syndrome, we see very varied picture in lot of post-COVID. Many of the times, what we come across is maculopapular rashes, sometimes vascular rashes also, vesicular. I'm sorry, vesicular rashes also, and sometimes this vesiculomaculopapular rashes getting infected and turning into pustules. So one have to be aware of that all these vesiculopapular rashes could be a post-COVID complication or a part of post-COVID syndrome, other than any other new dermatological injury.